Good morning, everybody. This is Neil Kalman. I'm chair of family medicine and community health at Sinai and CEO of the Institute for Family Health. And today we have a very special guest. I'm very pleased to welcome our grand round speaker, Dr. Jaime Schehr, who for many of you may already know her because of her longtime affiliation with the Institute for Family Health, I think over 15 years. We're grateful that she's here today to share her vast knowledge and experience about the very important topic of nutrition. Dr. Schehr holds degrees as both a registered dietitian as well as a doctorate in naturopathic medicine, making her one of the few practitioners to hold both degrees. She's been practicing in the field of integrative nutrition for 20 years and currently serves as the assistant director of the Integrative Family Medicine Fellowship at the Institute for Family Health. Additionally, she is owner of Schehr Nutrition, a consultancy providing expert guidance in nutrition and naturopathy. Dr. Scher's extensive career includes founding and directing dietetics programs, serving as chief nutritionist in clinical outpatient settings, co-founding a medical fitness testing facility. She serves as faculty at the University of Arizona Andrew Weil Center for Integrative Medicine and has been actively involved in various consulting roles for health-related companies. In addition to her clinical and consulting work, Dr. Schehr is deeply committed to education and research. She's served as a lecturer and preceptor at multiple academic institutions, including Hunter College, Columbia University Teacher College, and Touro College. She's also contributed to numerous research projects and presented her findings at many symposiums and conferences. We're very excited to have her with us today for Grand Rounds. Red?
Public area, so forgive some of the background noise. It's just a delight to have Jaime present. What I just can say is she's unique in her perspective of being able to bring her knowledge from nutrition and supplements to the FQHC setting and community-based setting. Frequently, our patients don't have access to this kind of expertise. And she's incredibly adept at not only her clinical skills, but also teaching our residents and students. And it's just a delight to have you, Jaime. Thanks.
Awesome. Can I take over or are we?
Yes, and we're going to go off camera. Thank you.
All right. Hello, everybody. So thank you for both of those warm welcome and introductions. So I will follow that up a little bit with, let me just share my screen so we can, hold on one second. Sorry, guys. Okay. So I'm going to follow that up a little bit. It is quite an honor. I have been here at the Institute for 18 years, which is scary to think about because that feels like a long time, but also doesn't feel like so long. So I am Dr. Jaime Schehr. I have been here for 18 years. I've got lots of experience in nutrition in all different capacities. And I hope that today we can sort of go through some of those things that I've learned and share them with you. And my goal here is, to bring a conversation to all of you around nutrition and how we can bring it into our visits with the perspective of it not feeling too heavy to do, right? I understand very well that everybody here on the call barely has any time for their visits as is. We are in a really, really challenging space around medicine and how much time we have with our patients and wellness and all that. So none of this is without a really, really deep understanding of just how challenging it can be to open up a conversation specifically around nutrition with your patients, because it can feel a little bit like Pandora's box, right? Like if I even ask, I don't know if I'm going to get out of this room. I don't know if I'm going to be able to walk out of here and if I'm going to have, the time to go see everyone else that I need to see. So I keep that, I tell you all that because I keep that really close to everything that we're going to talk through today, which is that I understand that nothing around nutrition is an easy in, but I hope that I can provide some ways to make it a little easier. So we're going to talk through nutrition both as a primary cause and as well as a primary intervention. And it's both, right? It is so deeply connected to cause of disease, and it is so integral into treatment and intervention of chronic disease. We'll talk through just different strategies that are applicable within the IFH and within FQHC communities. And then what can we do that will elicit behavior change in that space? I also threw in some more trending nutrition topics and headlines because nutrition is everywhere. We can't escape it. It's social, it's emotional, it's cultural, it's how we grew up, it's nurture, it's punishment, it's love, it's connection. And so even in conversations, if you're not at work, but at home, we're going to see this sort of nutrition permeates everything. And so there's some pretty big topics that are going to constantly come up both in your life and in your work. For example, fasting and intermittent fasting. So we'll touch on some of those as well. And then I would like to make sure that we have time at the end to answer some specific questions, because I think that is also something that is important that everybody can ask some questions. So no further ado, we have a problem, and I will not spend too much time because I think everybody knows we have a problem, but we have a big problem in this country. We have $142 trillion related to obesity. 318 billion is a CVD, as an all-cause mortality. And as we go through this presentation, the connection of our food and obesity disease is pretty alarming. The conflict of interest is what will make it the most challenging. So this conversation really is almost a grassroots. What can you, myself, what can we all do with that person in that moment to create change? Because we can't rely on it to come from top down right now. And so it's really golden handcuffs in that space. And then we're at such a disadvantage, especially within our marginalized communities, right? So we've all heard it and we all know it, that healthy foods are more expensive. And for the most part, they are. I will show you ways that they don't have to be. But generally speaking, if we're not getting really, really intimate with our patients around how to shop and what to shop for, healthy foods will feel more expensive. So the conflict of interest obviously comes from regulations and how we can serve our food and the foods that we are encouraging and promoting and allowing in this country. So this will not become a political conversation. I just need to make note that a lot of what we're about to uncover around food choice and disease is even that much more difficult, secondary to the fact that it's target marketed to communities, marginalized communities. It's incentivized to marginalized communities. And then the opportunity to have other foods, which maybe would be healthier, really, there's such a barrier to access. So we have to identify that nutrition is a root cause for us to acknowledge that it's also a root treatment. So, excuse me. What does that look like? Well, we have to identify that diseases, cancer, dementia, pain disorders, pain is a very big one, right? We deal with a lot of pain disorders in our clinics, directly connected to inflammation and oxidative stress, which if we take that back, and you'll see in the next slide, is directly connected to the food that we eat. Metabolic health, right? We have a diabetes crisis, an insulin resistance crisis, a pre-diabetes crisis. And how can we create recommendations in our visit to start to address this? The microbiome is fascinating, and we are only at the very, very, very infantile stages of really understanding the impact that this has. But if we know it as an organ of bacteria communication, and we can take this concept that the gut bacteria literally feeds off of what we eat, then it really is important for us to think about how disease is connected to that, and then what we can do with our food to address that, right? Inflammatory bowel disease, autoimmune diseases, mood disorders, spectrum disorders, all have well-founded connections and research to food. And then there's some genetic predispositions that we can talk through. So, I feed it back to all of you to say, if we understand that nutrition is a root cause or an exacerbating cause of disease, then can we also recognize that dietary intervention is a primary prescription? And that is what I would like to see shift. I would like to see us prescribe food and prescribe lifestyle modifications, not in place of medications, perhaps in addition to, or in the right time. So what does that look like? Well, if somebody's presenting with an inflammatory disease or some disease connected to oxidative stress, where would we start? We might start with antioxidant foods. We might start with fiber, anti-inflammatory food choices. I promise I'm not going to just send somebody away with an anti-inflammatory diet that is also struggling to be able to afford to put food on their table, right? But if we want to think of nutrition as a primary intervention for a root cause disease, then we have to think about what recommendation, what prescription can I give this individual in this moment that will make a difference? When somebody comes in with metabolic disease, what can I do? And we're going to talk exactly what that looks like next to encourage them to reduce the sugar that they're consuming. And maybe in reducing sugar, we also need to increase fiber to create a different response in the body of how we're handling and how our blood sugars are responding. And then we'll talk a lot about protein as well, because it's a really controversial nutrient in the nutrition world right now. Microbiome, right? There's pre and probiotic foods. They can be fancy and expensive if you're in Whole Foods. They can also be extremely inexpensive and readily available if we're aware of what they are. Our microbiome needs fiber. Our diets are lacking fiber tremendously. And then there's a lot of interesting research around artificial sweeteners and microbiome and the exacerbation of disease. And can we use artificial sweeteners, if needed, as a tool to get somebody off of sugar, or can we avoid using them altogether? And then there's some genetics and some personalized changes, and we'll talk about what that looks like specifically, right? So if we have somebody that has atopy and eczema, and there's a really strong genetic there, that individual coming in with significant eczema repeatedly, they may be using hydrocortisone to address the eczema, which will help in the moment. That is addressing the symptom. But if their eczema is exacerbated by an inflammatory diet that's high in sugar and, let's say, dairy, because that's a pretty big trigger for eczema, then using the medication, which is important in the moment to help with the exacerbated response, isn't treating the root cause if we're exacerbating that root cause through diet. So what can we do with that individual in that moment to say, hey, your eczema, I mean, it's really uncomfortable, it's really bad, we're going to use this topical, but have you tried switching your whatever the review of food might be? So for me, I might say to somebody, hey, do you eat a lot of dairy in your diet? Do you have a lot of yogurts and ice creams, milks? Maybe we could try switching your milk out for a couple of weeks and see if it makes a difference with your eczema. What if we switched some of your dairy products? I'm not taking everybody off dairy. I think dairy is an incredible food. I think it's an extremely foundational food in a healthy diet. However, what I will say is that in people who have exacerbated eczema, we see that when we remove dairy, there tends to be a positive response to the eczema. So that might be an example of using personalized diet in a genetic susceptible condition. So let's dial this down a little bit further. We know it's an inequitable system, and we are really climbing a tremendous uphill battle here. And the consumption of added sugars is directly connected to metabolic disease and obesity. This one for me is the most important thing I could speak to all of you about this morning. If we all walk away from this call with having learned nothing or encouraged nothing except getting your patients to reduce their sugar consumption, particularly from sugar-sweetened beverages, you will make a massive difference in the outcomes of health and obesity. So sugar-sweetened beverages are the second most purchased item in SNAP. Let me just set the tone for that for a second. Using SNAP benefits, you are not allowed to buy hot food. So you cannot buy a plate of rice and chicken, but you can go buy 2 liters of Coke. This is not an argument of personalized choice. This is not well, people should be allowed to buy whatever they want. This is a situation where we have the second greatest consumption of foods through our SNAP system coming from a food that is directly connected to a 62% increase in disease. To me, this is the equivalent of letting people buy cigarettes on SNAP. There is not a nutritional value in soda. There is not a nutritional value in sugar-sweetened beverages. There is not a benefit to any individual having these regularly, but yet it is the second most commonly purchased food in the entire system of subsidiary foods. So what does that look like? It looks like in the visit, instead of saying, hey, it'd be a good idea if we lost some pounds, your A1C is going up, try reducing your sugars, or maybe getting out and moving more, all good recommendations. But what's tangible? What's tangible is saying, hey, we really, really know that there's a lot of connection to disease when people drink their calories. Do you drink soda? Do you drink juice? Do you drink energy drinks? Do you drink Starbucks or Dunkin' Donuts? In 30 seconds, you can say, hey, I just want to see if we can cut down on some of the sugars that we have in our drinks, right? Tell me the 5 things that you drink throughout the day, or what are the most common things that you drink? Oh, I go to Dunkin' and I get a Frappuccino. All right, can we switch the Frappuccino to just straight coffee with a little bit of sugar? Or how about, oh yeah, I don't drink soda, but I drink juice. Okay, can we get off the juice, right? No, I don't drink soda and juice, but I drink Red Bull. Whatever it might be, that very, very small conversation, even though it's not going to feel like a lot, can have a massive change, right? So when we're encouraging somebody to reduce their sugar sweetened beverages, you are specifically asking them, hey, do you drink these? The second thing you're asking them is, have you tried to switch them? And we need to be able to do that with a very tangible, clear communication. So what I will say to someone is, hey, did you know that quitting soda alone, just if you walk out of here and do nothing different, you still eat what you eat, you still do what you do, you don't even pick up any exercise habits, but you quit soda, juice, and sugar sweetened beverages, next time you come in here, you'll probably be 10 pounds lighter. It's pretty darn motivating. Most people are like, really? And they're up for the challenge. And I'll say, yeah, sure, we can. Have you tried seltzer, maybe Spindrift? You know what? Take the juice that you have and pour like an inch of it into your seltzer. And like, can we just start there? Can we change the Frappuccino to the coffee? Whatever it is, they're not complex science concepts. They're encouraging extremely clear and specific changes. And there is not a greater need for intervention than that of reducing the sugar sweetened beverages in this community, because that is what we know is so heavily tied to metabolic disease, which is really our biggest concern in the nutrition and wellness space. I put this study in here. I put a few studies in here. You guys I'll share the slides with everybody. This came out 3 days ago, which is why I put it in there, because I thought that was pretty cool, sort of the relevance of it. It is the increased risk of AFib to sugar sweetened beverages, actually an even exacerbated version of that risk for artificially sweetened beverages. So the great debate over artificially sweetened and sweetened beverages will not go away anytime soon. I will not get involved in it as far as personal opinion, other than if we can get somebody off of all of that together by way of looking at the research, we're going to be doing benefit to our clients, our patients. So this is an important one for me. I wanted everybody to see this. Here's a look at the latest or the last report on SNAP expenditures in our country. Number 1, meat, poultry, and seafood. Number 2, oh, sorry about that, sugar sweetened beverages. More than vegetables, more than fruits, more than anything else. This is a big issue. So if we're looking at this column here on the left, that says SNAP household expenditures. Our eggs are at the bottom. We'll talk about eggs in a second when I talk about cholesterol. Eggs can be one of the most beneficial foods for improving somebody's diet. But yet it's at the bottom of the list. And we've got sugar sweetened beverages right there at the top. It cannot drive this home enough. And listen, there's a lot of industry pushback. Why is this allowed? Why? Right? Because the truth is, industry is not willing to see the loss of financial resources from the high fructose corn syrup industry. There's a whole thing around it. We are not going to win that argument. We're only going to win it in the face-to-face time that we have with our patients, encouraging change. So let's take it a step further, right? So now what you have a patient who comes in, you've already assessed for sugar sweetened beverages. You're already really trying to encourage them to change. They might not, I don't like water, or water's too expensive if they don't feel comfortable drinking it out of the tap. We can do other beverages. We're just trying to move away from the sugar sweetened ones. But now we're going to look at what the next one is. We have ultra processed foods connected to a 62% increase for all-cause mortality. What? Again, goes back to that cigarette. We don't allow people to buy cigarettes or encourage people to buy cigarettes knowing that it's so connected to disease. But here we are in a system where we're really not encouraging for healthy habits or change. So ultra processed foods, this is this is within the FQHC. It's also just probably for most people on this call, if we sort of take a step back and say, yeah, it's a lot easier to eat ultra processed. It is significantly easier for me to get something quickly, open up a bag, right? So what is an ultra processed food? It's anything off the red side. It's anything that has technically 4 to 5 ingredients. It's packaged. It's not in its most natural form. So I'm just sort of created this chart to give an example of that. Wheat being minimally processed, flour being processed, cookies being ultra, right? I think we can all sort of follow the algorithm of what it looks like when something becomes ultra processed. And if you do a diet review of your patients, you will see that the majority of the foods that we are consuming, particularly in people with food subsidies, are ultra processed foods. It is not true that unprocessed or minimally processed foods are too expensive, because I can have somebody spend the exact same amount of money on a bag of frozen vegetables that they would on a 2 liter of soda. But most people aren't thinking in that way. They're not thinking, I can get a bag of no frills, brandless frozen vegetables for $1.99, for $1.29. Or I can get my soda for that, right? So we have to be able to say, hey, if you can't get fresh vegetables, then get them frozen. And if you can't get frozen vegetables, get them canned and then rinse them off. Because I would still rather have somebody have canned vegetables, even with hypertension, than I would them have something to drink that didn't have the nutrition value. But we trip over the truth. How many of my patients won't have canned vegetables because they heard canned foods are bad for blood pressure? But nobody ever talks to them about the effect of sugar on their blood pressure. And because soda doesn't have any sodium in the label, or only 20 milligrams, it feels like it's okay. But we're staying away from the canned vegetables. So when we are the practitioner and we are in the room, we need to be able to communicate things that are going to be super tangible. You know what? Vegetables can be expensive. And what's even more expensive is when we get a vegetable and we don't get to eat it in time and then it goes bad, because now we're just throwing money out. And that's crazy making. But if you buy them canned or you buy them frozen, they're not going to go bad and you're always going to have them there. Okay? So these are languages that we need to be able to use with our patients to really encourage that change. Now, I'm going to get to salt, I think, in one more slide. We'll talk about using salt to encourage intake of certain foods. But again, on the ultra processed food, like it's so easy for us to rely on ultra processed foods. And I would actually encourage everyone here who's listening in to think about in your own life, in your own foods, like, what am I eating that maybe is convenience and ultra processed, and where can I maybe switch that over? Because if we can do it for ourselves, we're going to have a lot more empathy when we try and do it for other people. Big connection to the way that we're processing our foods and cancer. Really, big picture, disease, chronic disease, cancer, metabolic disease, connected to food. I don't think anybody's going to walk into their doctor visit and use food as medicine to treat strep throat. You're not going to use food as medicine to treat an ear infection. But we should always be thinking first and foremost to be using food as medicine when it comes to chronic disease, because that's where we're going to see a change. Let's talk about blood pressure, another really big concern for our population. So most of the patients that I absorb who are referred to me for hypertension will come in and say, you know, I don't understand why my blood pressure is high. Like, I don't eat salt. I don't put salt on anything. And they don't. They know not to add salt to their food. So there's this frustration and they're like, well, I'm already not adding salt. So like, I don't know, I'm not adding salt. Because the communication to that individual was salt is bad for you. Don't put salt on your food. But with the communication that would be more effective, that we could switch to, would be the largest contribution of sodium in an individual's diet isn't from a salt shaker, but it's from a processed food. So instead of saying, hey, don't add any salt to your food, we could say, hey, let's think about foods that you get out of a package, out of a box, out of a bag. Because if it has a label, we can check the sodium. The DASH diet, which is the gold standard of recommendations of diets for people with hypertension, is a fantastic, well-founded, studied diet. But it means nothing if somebody doesn't understand what it is. It's like telling them to eat cardboard. What is dash? Other than Mrs. Dash, which is a seasoning, and that's not going to change anybody's blood pressure. So the DASH diet is okay, it's great, but often it's so far down the recommendation list of where we need to be to initiate that change. So what can we say to somebody instead of being like, oh, your blood pressure is high, don't put salt in your food, your blood pressure is high, you should follow a DASH diet. Well, if they don't understand what food is and where salt is coming from, the DASH diet is only going to tell them, if they go and look at the page, eat more vegetables, eat more fruits, and more nuts and seeds and fish. But we're missing the big picture there, which is, hey, we got to really zero in on how we can reduce ultra-processed foods contributing to the most amount of sodium and therefore having the greatest impact on your blood pressure. So how does that look in your practice, with your patient? If every room in the clinic had a food label, a little plastic, covered thing so we can wipe it down. If every single clinic visit had a food label there, you wouldn't always need it, but at any given moment, you can say to somebody, hey, do you ever look at this label? Because they actually list sodium on the label. And that's a really great way to check for salt in the food. So really just try your hardest to not buy foods that have more than 200 milligrams of sodium, because anytime we're eating a food with more than 200 milligrams of sodium, it can start to add up real quickly, and that can have an impact on the blood pressure. So guess what? If they pick up the package of Doritos or ramen noodles, or they're going to see 300, 400, sometimes 600, sometimes 800. And there's an instant connection there. Oh man, my doctor told me to find foods that are less than 200. And then when they go and pick up maybe a salted popcorn versus an unsalted popcorn, one's going to have 250, one's going to have 20. There is a direct connection to what they can do in a way that it feels and makes sense for the patient. And we'll often have patients come back to me and say, when you told me that I needed to have less than 200 milligrams of sodium, it was crazy when I went home and I started checking my cereals, my pasta boxes, my rice versus rice-a-roni, yellow rice versus white rice. All of these things are really, really big difference. So someone will say, I don't use salt in my food, but we're using a bag of yellow rice. And then I teach them how to use the label to find ones that are lower in sodium. This makes a massive impact. I'm going to thread this for you from hypertension to hyperlipidemia to insulin resistance. The other thing we want to think about is hypertension is not solely a manifestation of eating too much salt. Okay. Hypertension can come from obviously many other metabolic changes, obesity, but a high sugar diet is also a contributor to hypertension. We'll go back to biology and all that, but even just the simplicity of fructose raising uric acid and inhibiting nitric oxide, causing a rise in blood pressure. So if somebody has a sugar sweetened beverage before they come in for their doctor's visit, and then you take their blood pressure, guess what you're likely to see? A higher reading. We want to be aware of these things, and we really want to encourage change with a tangible, in a tangible way, I should say. And so if someone comes in, hypertension, I'm like, you know what? I know you're probably not putting salt in the food, but actually, I'd rather you have broccoli and put a little bit of salt on top of that than to not have the broccoli because you don't like the way it tastes if it doesn't have salt, but instead we're just having something out of a bag, right? Or something out of a can or something processed. And then teach them about the label. I think this is really important. Or make it a part of our visit summary where we can write that down and highlight it. This was an awesome study. There's been a few of them. I will admittingly say that my knowledge on sort of current policy and what's available for patients in New York City changes so much that it's just not my strength. But there have been many iterations of farmers market and prescription produce prescriptions for patients. And the feedback and sort of the response of these is never negative, right? It's not like, oh, I went to the farmer's market and my diet got worse. There was a significant improvement in vegetable and fruit consumption and a decline in fast food consumption in this study, which looked at produce prescriptions for patients with hypertension. Imagine we gave somebody a prescription for a voucher to go spend $15 at the farmer's market. Or sometimes it's not even at the farmer's market, sometimes it's in the grocery store. So there's no, I mean, this is just one of so many studies that look at what happens when we actually, in our visit, make this a priority. Because your patient's leaving, listening to what you're saying. And if you're prioritizing this, they're prioritizing this. Maybe not as much, maybe not directly, maybe not the first time, but this is how change happens. So talk about cholesterol. Cholesterol is so widely misunderstood. And I don't mean from the practitioner perspective. I mean, I guess if we start looking at how different providers look at cholesterol, we could say that too, but I'm really talking about patient. What is cholesterol? It is so confusing for a patient because you don't really eat cholesterol. Cholesterol is not what readily or widely available in food. If you have somebody go scour labels for cholesterol, they're going to come back and be like, hey, doc, I don't actually eat that much cholesterol. I checked all my foods. No cholesterol. I checked all my foods. I only got 30 milligrams of cholesterol today. Cholesterol is determined by the amount of fat and carbohydrate. So when we want to initiate changes for hyperlipidemia, for elevated blood cholesterol, elevated triglycerides, we want to make sure that we are speaking about the combination of fats and carbohydrates in our diet, not about cholesterol. So I threw this next bullet in there, kind of cheeky way to say, can we stop demonizing eggs? We have dispelled that rumor so many times over. Eggs are not the evil food. Eggs are not the devil, and eggs are firm. They are not, we'll say this, eggs are not the reason that we have high cholesterol. Actually, it is very often that I see somebody stop eating eggs because of their cholesterol, and they replace it with a bran muffin or a pastry, further exacerbating cholesterol. So I'm not saying that everybody should have a, 12 egg yolks per week. I am saying that we should be able to encourage people to eat eggs, and we can do egg whites. That's also fine, because we want to say, hey, it would be really a great idea if we could reduce some of the fats and sugars, but not sort of focus on the cholesterol. I see this a lot. So what does it mean when someone has hyperlipidemia, and how do we make dietary recommendations? We're going to talk to them about saturated fats. We're going to say, hey, let's take a look at the label, and let's take a look at making sure that there's not a tremendous amount of fat in these foods or in these. If you compare the label of a muffin to the label of a granola bar, we can see a huge difference, right? Our saturated fats are going to predominantly come from our pastries, and then of course from our meats, which we don't have labels on. I'll talk about that in a second. So when it comes to hyperlipidemia, yes, let's avoid fried foods, try and stay away from fried foods, try and stay away from a tremendous amount of animal fats, but also can we avoid the cookies, the pastries, the donuts? A donut, highest amount of cholesterol you're going to see in most standard American diets. Donuts are delicious, but we don't want someone to skip the egg sandwich at Dunkin' Donuts and get a donut or a blueberry muffin because they have high cholesterol. And I see this every day. I used to have the egg sandwich, but my doctor told me I had high cholesterol. And so now I moved over, I'm getting the blueberry muffin. We don't want that. So the specific and clear intervention for the individual would be taking a look at the label together and sort of saying, hey, see, so this food actually has 0 cholesterol, but it's got a lot of saturated fat. So we want to really make sure that we're monitoring those. Now, you might have somebody that comes in with insulin resistance, hyperlipidemia, and hypertension. And you're not going to teach them to read every single thing on that label. So we're going to prioritize this in a second and say sort of what is our most important. But the idea here is that we're not using big concepts like DASH diet or cholesterol in foods, because we're going to lose our individual. We're going to lose what that actually feels like, what the tangible is. So this is an awesome study that said the potential impact of cost effectiveness of a salt and sugar reduction target for the country and what that would look like, right? And this was an actual study that looked at, hey, if we have as a governing board in a country make efforts to reduce the salt and sugar in our food system, then what would that look like? And the estimation of the study, this is such a great study, it's actually relatively new. Look at those numbers, 2.4 million CVD events, 500,000, 0.49 million CVD deaths, 0.75, diabetes, like this is a reduction. 160 billion it could save. Do you know what the obstacle to this study was? They had less than 50% industry compliance. Dead in the water. The industry is not willing to put these recommendations out there, the financial investments. And so we don't have, this was a micro study, right? This will not happen. This will not happen across our country because we can't get industry buy-in. What a cool way to look at what would happen if not just from you, from the visit with your patient, but if from a big picture, we started to say, hey, we have to do better. This is a true story. My daughter came home from school last week and I give her cucumbers in her lunch. And I put salt on them because you know what? She's not going to eat them if I don't. She's just not. Cucumbers are going to come home and they're still going to be in a little plastic container. She's not eating them. Put salt on them, kind of more like a pickle. She's eating them. She comes home last week and she's like, Mommy, one of my friends at the table told me that the salt was really bad for me and I shouldn't be putting salt on my cucumbers. And I was like, oh, okay. We had a little conversation. I said, well, what's your friend eating? She's like, oh, well, she gets the pancakes in the bag from school lunch. And I was like, okay. And of course, I mean, the end of conversation there, like, you know, I just encouraged my daughter that eating cucumbers with salt was healthy. The point was, there was such a moment for me where I was like, here we are, demonizing, not the children per se, it's not their fault, but it's the concept of demonizing this idea of using, this was sea salt on cucumbers, but actually making it okay to have rainbow colored pancakes in a bag from school lunch. Now, access to food is huge. And I'm not sitting here saying that, you know, that for some people, that's the only food they're going to get. And that's very important. But what I'm saying is that we got it wrong in how we're talking about food and how we're encouraging people to eat food and to be able to communicate these things. So I really do believe that it starts in the home and it starts in the doctor's visit, right? It starts at home for us teaching our own selves first, right? Because if we're not doing it, our kids aren't doing it. And then teaching our patients, hey, I know changing your diet is extremely challenging, but let's just do this one thing. Let's see if for the next 30 days, you can cut it. Can you give up soda, right? Just for 30 days. Can you read some labels? Like, there's a million different methods that we can use. And sometimes just having a conversation and knowing the personality of the individual in the room will help you decide which of those is going to be the most important. Insulin resistance is, for me, something that is extremely important because I think that insulin resistance is not just diabetes, but it is hypertension, it's hyperlipidemia, hypertriglyceridemia, obesity. It's multifactorial. It is so impacted by our diet, our exercise, our sleep, our lifestyle, medications that we take. We see that all the time, especially with certain psych meds. It can really have an impact on blood glucose and insulin. Fiber. One of the things I say more than anything ever, I probably have said it 10 million times at this point, is vegetables should be half your plate. Literally. Plants should be half your diet. So how can we make your plate half vegetables? How can we keep the rice and keep the chicken, keep the pasta, keep the meatball? But what can we do to make sure that 50% of your plate is vegetables? It might mean frozen, like I said, or canned. Increasing fiber is going to benefit insulin. It's going to benefit blood glucose. It's going to benefit hypertension, hyperlipidemia, hormone management, hormone balance, mood disorders. Yes, it's even going to impact and improve IBS and IBD. We might need to make some slight changes in there, like cooked vegetables versus raw if it's IBD, but there aren't many situations where fiber isn't going to be a primary important nutrient to improve the quality of our diet. And also, it's the nutrient we're lacking the most. We're not lacking sugar. We're definitely lacking fiber. So when I think about insulin resistance, I think about fibers. And if you have a label, you can check the sugar and you can check the fiber. So here's a great example. What do you have for breakfast? Raisin Bran. Okay. Well, we're going to look at the label of Raisin Bran together. We're going to see that Raisin Bran is extremely high in sugar and has 2 or 3 grams of fiber. So you know what? This is a great cereal for fiber. It's really high in sugar. But you know what? Bran flakes. Same price, same size box, same company, no sugar. So now we just reduced 20 grams of sugar or more, because most people don't eat a single serving of cereal. Most people eat multiple servings, by simply moving from Raisin Bran to Bran Flakes. And most of the time when I say this to my clients, they're like, I thought Raisin Bran was good for me. I thought it was doing something good. And I'm like, Raisin Bran is 22 grams of sugar. Have 2 bowls of that, the equivalent of 2 or 3 Snickers bars for some people. But Bran Flakes are fantastic. And if we need to put some fresh fruit on there, or even a tiny bit of raisins on your own, you're still getting less sugar than the actual cereal itself and less sodium. So these are very small changes that we can make, right? So if we're looking at the label again, we're thinking about how can we limit foods with more than 10 grams of sugar? Well, if you gave that recommendation to your patient, they would turn around Cheerios, Honey Nut Cheerios, and they would pick Cheerios. They would turn around Corn Flakes and Frosted Flakes and pick Frosted Flakes. So they would turn around Raisin Bran and Bran Flakes and pick Bran Flakes. Now, could we make an even better decision than Corn Flakes? Sure, of course we could. But we're not looking for perfect. We're looking for what is better, what's good, better, best. Like this is an algorithm of how to move somebody from what they're doing now and make it a little bit better. So I say that to say what we can do here is we can say to somebody, hey, check that label and make sure that it has less than 10 grams of sugar, because that's going to make a huge difference in their drinks, in their cereals, in their pastas, in their rices. I've picked up bags of rice or beans in the grocery store, and they have a lot of sugar in them, right? Baked beans. And you're like, uh-oh, we're getting people to eat more beans, but this one has a lot of sugar in it. So we have to use a language that makes sense to them. So anything higher than 3 grams of fiber is going to be a good source of fiber. Anything lower than 10 grams of sugar is going to help us bring some of those sugar levels down. Don't really have too much time to sort of go through the what this does, but really I think that we have to think about insulin resistance as more than just sugar, even though it's a huge impact, and what that would look like. So one of the things that I did not say here, let's just go back here for 1 second. One of the things that I did not say yet this far, and this is a conversation and a grand rounds all about nutrition, but I would be remiss to not say this, is that in the same vein that I'm speaking about the importance of reducing our sugar and being able to speak a language to our patients around food that makes sense to them, we also need to do that for movement. We are entirely too sedentary as a community. And I think the greatest obstacle to this is the overwhelming feeling of what it would look like to start an exercise program for most people. Can't do it every day. I don't have time. I can't get to the gym. I don't have the money, all of it. And this isn't just for our patients. This is probably for a lot of us on this call here too, where it's like, there's just an obstacle. I'm really, really deep in loving the research right now on NEAT. NEAT is non-exercise activity of thermogenesis. And some of our longer studies are looking at people who don't exercise, but have a great amount of NEAT and they're active in their day, are healthier than others who maybe even do exercise. So I'm not saying we shouldn't exercise, of course. What I'm saying is that we also, in conjunction with making recommendations for people to improve their diet, we really need to drive home what it looks like to be less sedentary. And so I always say to people, I'm like, you know what? You don't have to go to the gym. You never have to step foot in a gym. You don't have to take another exercise class. You can turn on the music and dance in your home. We can do YouTube. It's free. We can get off the bus early. We can, vouch to not take the elevator. And then a lot of times pain is an obstacle to movement. And unfortunately, it's a little bit harder of a conversation, but pain is also the antidote to it, right? So movement is also we know that movement can also improve that. So I needed to say that because I don't want to go through this whole presentation and not really highlight the importance of also encouraging reducing a sedentary lifestyle, which is another really impactful part of our conversation around wellness. Just another study on the importance of vegetables. Okay, I'm going to switch gears for a second because we can put a label in every room in the clinic and we can start talking to our patients about really driving home a greater intake of vegetables and less sugars and less saturated fats. And one of the biggest things is really, stop tripping over the truth, right? We get stuck on this idea of like, oh, salt is bad. And then we don't think about how that communication might have a bigger impact. So I do want to switch gears because this is a conversation that a number of you have asked me to touch on, which is the GLP meds. You can't get out of a nutrition conversation right now without having this come up in some capacity. I will not stay on here too long, but because a number of you asked, here we are. I have a tremendous amount of patients on this medication. Coverage remains the greatest obstacle, particularly in Medicaid plans. I don't have an answer for that. It's extremely frustrating that some of the population that needs this access to this medication the most doesn't have it, and it won't likely right now. This does not replace the need for nutrition counseling or for nutrition attention. Actually, I would say that it increases it tremendously. What I will find is that a lot of people with, especially with morbid obesity, or severe obesity or very high BMIs, they do require continuously increasing dose. This is one area where I have seen there be like the communication around the dosing for this is a little challenging, but we will see plateaus in weight loss, not so much in smaller amounts, but in larger amounts of necessity for weight loss. You're going to see a plateau pretty quickly until you get to your highest dose. You've got to have a protein focus on this, or the ability to sustain the weight loss with these medications is going to be less and less. Hydration becomes a critical component for preventing bowel-related side effects. The desire to drink water, now I'm thirsty as I'm telling you guys this, of course, but the desire to drink is very, very minimal when you're on these medications. So we want to make sure that we remind patients that the likelihood of less GI side effects is greater if they stay hydrated. Same thing with fiber. And then we are going to see a lot of muscle loss. And to counter that muscle loss, we do really need to emphasize strength training, again, with the protein. So not getting too much into the nitty-gritty of this, but metabolism, the rate of your metabolism is dependent upon how much muscle mass you have, right? And what we're seeing with a lot of these medications is that although there's a tremendous amount of weight loss, there's also a tremendous amount of muscle loss. So we're actually creating a lower basal metabolic rate, making it harder to keep the weight off, unless we really do focus on protein and strength training within these capacities. Strength training meaning that they're doing something that would encourage muscle building. Again, doesn't have to be in a gym, it can be home. But I wanted to bring this up because people are asking about it. Lots of patients will come in and ask about it, and I am not anti-GLP meds. I think that they're tremendous. I think that it's phenomenal. I mean, listen, probably most of you on this call know this, but pop quiz, what was the first peptide ever invented? Insulin. Right? And so this field of medicine is going to be probably game-changing in regards to chronic disease and management. But one of the things I really encourage is for us not to then ignore that no matter what the disease, no matter what the medication, we as the individual human still need to be front and center in the recommendation. So if your patients are on this, here's my recommendations. If your patients are asking about this, obviously access is a challenge. Another thing people ask about a lot is longevity. This is all the rage right now. Health span versus lifespan. It's essentially what I'm talking to you about, right? I'm really, really sort of driving home this idea that we can use food as medicine and food as prevention. And the idea here is to create longevity that is healthier, not just longer. Protein is everywhere, and I think it's really confusing because we don't know how much protein to eat. We don't know what type of protein. I have patients come in all the time who are like, I don't know, and I heard eating protein is bad. I stopped having animal proteins. And so now I have a bagel for breakfast and I have a sandwich for lunch, and I just put, cheese on it. And then I have rice and beans for dinner because we stopped having protein because animal meats are bad. There's so many thoughts and theories out there. There's no best diet. There's not. Vegan is not better than omnivore. Omnivore is not better than vegan. Documentaries right now are saying like, wow, this diet is best. It's not true. There is no best diet. The best diet is going to be the one that your patient has access to that is healthy. So if we let go of the titles and the principles and some of our own biases, and we all have them, every single one of us on this Grand Rounds has one, then we're going to say, you know what, it doesn't actually matter what it's called. It matters what's in there, right? So protein, I needed to put this in here because it is something that is very confusing for people. And I would argue that a lack of protein is one of the things that drives up our intake of sugars and carbs. When we are not satiated from an adequate protein, I see it all the time. We eat more carbs and we eat more sugars. I don't care if it's plant protein or animal protein, but if you're not eating enough protein, you are going to eat more carbs and sugars. What is more connected to disease than protein, carbs, and sugars? There are very, very few diseases connected to excess protein intake. And they're not public health crises. They're individual, smaller number, maybe kidney issues, but protein is a nutrient that we are not eating enough of. I mean, I'm not talking about like exercise circles, but I'm talking about just in our day-to-day patients. It's also more expensive, right? It goes back to that thing that we talked about before, which is cost of food. It's really cheap to eat sugars and carbs. To sum this slide up, I will say that 0.8 grams per kilo is the RDA. That is a modest minimum recommendation, and they will even say that, right? That's like sort of the basic needs. When you are following the basic needs, then you are more likely to have excess of the others. So, and then for optimal metabolism, I encourage people to get closer to 1.2 grams per kilogram, not per pound. If you're on social media, then you're really confused because social media has a fantastic debate over this. And what I'm saying here is follow the guidelines, but we know that's a minimum, so we actually need to increase that ever so slightly. Coming to the end here, I just want to touch on fasting. I get lots of questions about fasting. Intermittent fasting, should I intermittent fast? Should I not? It's an individual question. There is no best diet. There is no one that's good for everybody. What I will tell you is that intermittent fasting is not fasting for longevity. Intermittent fasting is a way of caloric restriction, which is another form of a diet, and that's not bad. Sometimes intermittent fasting can be really great to get people to stop eating late at night, but it also can be a trigger for people to eat more later on because they skip breakfast because they're intermittent fasting, and then they're so hungry later that then we're breaking that fast and then we're eating later on. Assess it on an individual basis for sure. So we need to assess dietary habits from an awareness experience, right? Like, what is somebody doing and where are they now, and how can we move one step closer to them? Meet them where they are. We've got to be collaborative in this, right? Ask them what they do instead of telling them. The worst thing you can do is like, just tell somebody, oh, you need to lose weight. And they already came in and you didn't know this, but they've already lost 30 pounds. And now we've sort of stepped on their foot a little bit and they're hurt because we didn't acknowledge that they've lost some of the weight and they already were just looking for, the comfort in that space. I have been at the Institute for 18 years. What makes the most impact on speaking about diet with any person I've ever worked with is getting to know them a little bit and not putting my perspective or my agenda, but understanding where they are and getting in that way and who they are, what they're looking for, where they struggle. So the individuality of your nutrition counseling will determine the effectiveness of it. And then what are the 4 things that we can do? Well, I talked about this before. I talked about NEAT. I mean, if I could say one thing, if everybody could just do one thing, it would be eat more vegetables. Because if they eat more vegetables, then they're going to eat more fiber. So now I just got 2 things. And if they eat more vegetables and they eat more fiber, then they're more likely to have less sodium, right? So that one recommendation of eat more vegetables actually then sort of trickles down into so many other recommendations. Assessing for sleep, stress, and lifestyle makes a big difference because what happens when we're sleep deprived? We look for sugar. What happens when we're stressed? We look for sugar. What happens when our lifestyle is too busy? We look for convenience, AKA ultra-processed foods. Taking it a step further, there's so many things that we can do. Establish routines with your patient. What's one thing that you guys can come up with together? If they have the financial means and they're somebody who's wearing a wearable, that's a great device that we can use for positive feedback of change. And then being a support system, whether it's you, whether it's somebody at the Institute, whether it's a care manager, case manager, or whether you have them sometimes come in with their partner or friend or that support, whether it's, online community or actual connection and community is really, really important there. So I'm going to end on that because I know we don't have a lot of time and I do want to be able to answer questions, and to deliver anything effectively around nutrition in a matter of 45 to 50 minutes is extremely challenging. So I hope I just sort of skimmed the very top. I'm going to go through some of these questions, which is some of this info available in Epic? I don't know, but that's definitely a conversation that I can talk to the team about and sort of say, how do we get that plate and how do we get that food label in there more easily so that providers can access it for their patient visits. For plant-based patients, sometimes we see more carbon ultra-processed plant. Absolutely, 100% this is true. When I see plant-based patients, if they are not extremely careful, they then wind up having a higher ultra-processed carb. Vegan plant-based doesn't mean it needs to be ultra-processed in carbs. It's just a lot easier to. So in that situation, I would assess for why are they plant-based? Are they plant-based because someone told them that it was better? And we might be able to bring something in like eggs that would help get their protein needs. Things like tofu, in these particular individuals, I would talk about how things like tofu, nuts and seeds, right? Those are all foods that we can use to help decrease them relying on ultra processed carbs and plant foods. I'm not a fan of Beyond Meat. I'm not a fan of those sort of ultra processed plant-based proteins, because I think it is doing exactly what I just said. It's taking something that's healthier and ultra processing it. So it's teaching the patient that. It's saying, hey, why don't you eat meat? Why don't you eat protein from meat sources? And if they're against it, then saying, okay, well, can we do tofu instead of Beyond Meat? Can we do, almonds and nuts? Can we do beans, but maybe leave the rice out, since we already have so many, we need a lot more beans to get our protein. So maybe we don't need to put it with another carb, because that would be loading it up too much. Is there a place to do nutrition advocacy, like around healthy food access, or like what you said, around? I don't know. That's a good question. I don't, that's sort of a question I don't know too much about the advocacy space. What do I think about nutrition apps, and what do I think about fiber supplements? Okay, I think nutrition apps are fantastic. If we can replace Instagram with some sort of nutrition app where you get to look at healthy foods and recipes and log your foods, great. Or if we can, put apps on our phone, and a lot of them are free, right? I want people to pay more attention to this. I've never met a nutrition app that told somebody to eat less healthy. I've only met nutrition apps that encourage people to eat healthier. So if somebody wants to download a MyFitnessPal and start paying attention to different tips that come in when they log foods, those programs are fantastic, and so many of them are free. And I mean, there's a lot of them. So I'm a fan of them, because it just means that somebody's paying more attention, right? They're dialed in a little bit more to their food and to their habits. And then what do I think about fiber supplements? I actually think fiber supplements are important. I think that I don't love Metamucil as much as I love some of the other ones. I like Sun Fiber, which is like Wargum, Fluorosophy, Biome. There's a couple of them, but I think fiber supplements are important, especially for people who aren't eating enough fiber. Sometimes vegetables and fruits in excess can cause GI distress for some people who have digestive issues. So using a fiber supplement can help meet fiber needs. It doesn't replace the vegetables, but it can help meet that total number. We should be getting 20, 25, 30 grams of fiber a day. Our patients aren't getting that, not even close. And using a fiber supplement can absolutely help that. So I very much am a fan of using fiber supplements. And Metamucil is fine. It's Benefiber, Metamucil. They make ones today that are tasteless, and that for me has a greater compliance, because some of those like orange flavored ones, they're also very stigmatized as like your grandparents' medication, right? So yeah, so it is 9 o'clock, and I think we're right sort of at that point of stopping, unless there's any other questions. And I am at the Institute, so you guys can find me and message me, and I hope to be able to continue to answer a lot of these questions and do more of this in the future. Again, it is such a small amount of time to cover such a big issue, but really, really encouraging change through intimate suggestions is what I am hoping all of you can walk away with.
It's so important. The perspective you give is so important, which is really, how do you apply this in the clinical visit? It's not just about the science, but it's about how you interact with your knowledge of popped with patients. Red? So you just
I was just gonna, Jamie, thank you. Just the idea of food as healing is just such an important message that we need to remind, because it is one of the things we do on a daily basis that really can promote our health and well-being. And I think in the terms of those of us who are family doctors, it's a conversation about families and how families prepare meals together.
Yeah.
So, just a wonderful summary, and we're really glad to have you part of our faculty.
I'm honored to be here. This was great.
you.
Thank you guys so much for spending your Friday morning with me.
Thank you.
All
Really
right,
appreciate it.
have a good breakfast.
Great.
Take care.